Hello, my name is Van de Keyser. I am a neuroradiologist in Ghent University Hospital in Belgium, and welcome to this presentation on how to read a brain CT. This presentation will cover the basics of analyzing and interpreting a CT of the brain and is mainly aimed at medical students and young radiologists at the start of their career. At the end of this presentation, you should be familiar with what a CT looks like of the brain. You should be familiar with the basic anatomy of the brain and recognize it on a CT image, and you should be able to recognize some of the most common pathological entities on CT, like an ischemic stroke, hydrocephalus, or an intracerebral hemorrhage. What are the topics I'm going to cover? I'm going to start with a brief description of the physical principles of CT. Then we're going to discuss basic brain anatomy, followed by a discussion on the imaging appearance of several pathological entities like an ischemic stroke, an acute cerebral hemorrhage or intracranial hemorrhage, hydrocephalus, brain herniation, and then some other entities I believe every radiologist should be able to recognize on CT. Let's start with the basic principles of CT. What is a CT exactly? Well, this is a CT machine. It's one of the CT machines we have at our hospital. And as you see, there's a table and the patient is positioned on the table, and there's a huge tube here, the so-called gantry. The table moves through the gantry, and while the table moves through the gantry, there's an X-ray tube moving around the patient in the gantry, emitting X-rays. And that is basically how a CT machine works. So this is a nice drawing I made. What are the main components of the CT machine? Well, we have the central table on which the patient is positioned, and in the gantry we have the rotating X-ray tube, but also present in the gantry are a ring of stationary detectors. The X-ray tube emits X-rays, photons, and the energy of these photons is detected by the stationary detectors present in the gantry. Now, the X-ray tube moves continuously in one direction. I was not able to create an animation with the X-rays, but it also means that the X-rays are also continuously rotating, or the X-ray beam, the fan beam, is rotating as well. Now, this happens while, so the X-ray tube is moving around the patient, emitting X-rays, and at this specific moment, the table is moving through the gantry. So if we were to look at what the transmitted radiation looks like, it will take on the form of a spiral or a helix. This is how the current generation CT machines works, and this allows us to scan a large anatomical area in a single breath hold. It's a way of scanning very quickly, because in the old days, a scan was made slice by slice. This is no longer the case with current generation CT scanners. Now, what interests us the most is the image, but it's good to have an idea on how this image is created. So afterwards, the data is analyzed by the computer, and 2D, two-dimensional image slices of the patient are created. How does that happen? Well, each of these slices can be subdivided in a matrix of 512 on 512 volume elements or voxels. Sometimes it's 2024 and 2024, but never mind that. It's not that important now. And during the CT examination, each of these volume elements, each of these voxels has been transversed by numerous X-ray photons, and these carry a certain energy with them, which can be detected by the detectors located in the ring of the gantry. Now, this is an example of X-rays passing through the slice. So they are transmitted here by the X-ray tube, and let's say a certain number of photons are transmitted, the number X. They go through the air, and well, because they never encounter anything, most of them will reach the detector. So let's say about the same amount of photons reaches the detector on the other side. What happens if X-rays are transmitted that pass through a structure such as the brain? Well, some of these photons will be absorbed in the brain tissue or will be reflected by the brain tissue or by the skull. So the number of photons and the amount of energy reaching the detector on the other side will be lower. It will be the number of photons X minus the number of photons that are absorbed or reflected. Now we have a value of how much photons reach the other side, but that does not allow us to calculate how much photons were, let's say, reflected or absorbed at a certain point in space here. So we only know how many went through it. How does a CT machine work? Well, basically, we do that operation in multiple directions, and at the end of the day, we get a matrix of values, and then we can calculate for each voxel how much X-ray energy, how much X-rays or photons were actually absorbed or reflected, and that's something we call attenuated in a specific voxel. And that's very interesting. So the intensity, as said, has been transmitted or has been measured by the detectors. And from these intensity measurements, the density or the attenuation value of each specific voxel can be calculated. So basically, what the machine does is it doesn't really generate an image, it generates a number of values, and these values reflect how much X-rays or photons were absorbed or reflected in a specific voxel. And that depends on the kind of tissue that is there. And if we then translate these specific values in a grayscale, well, that will allow us to generate an image. So it's basically translating these numerical values in grayscale in an image form, and that is what we look at when we look at a CT image. Let's move on to the next slide. So this is the matrix containing all the values. We can already see or recognize the shape of a head in those, and that is what the CT image would look like. Now, very, very basic. Now we're going to analyze the CT image, but the basics of the CT image. And to put it very simply, structures that are black on a CT image are called low-density structures, and a lot of photons were able to pass through them. So not a lot of energy was absorbed or reflected here. We call those hypodense structures. And then we have structures that are very dense, hyperdense, and these are structures through which photons were not able to pass, or a lot less of them were able to pass through them. So there was a lot of attenuation of the X-ray energy in these specific structures. There is something we use as radiologists, and it's called the Hounsfield scale. So I said that each voxel has been given a certain numerical value, and I don't really know how these values, what these values are measured in, but to make things easy, Godfrey Hounsfield, who invented the CT scan, developed a scale that we call the Hounsfield scale, and he said, let's just give the attenuation value of water the number 0. So that will be the reference point. And let's just give all other attenuation values, relative values, compared to that of water. So that's what we do in the Hounsfield scale. We give water an attenuation value of 0, and then all other attenuation values are compared or calculated in comparison to the Hounsfield unit of water. And then we have structures that are hypodense compared to water, have a lower attenuation value. A typical example is fat. Fat has an average Hounsfield unit of -100. And of course, air has a very low attenuation value because there's basically almost nothing present in air that can reflect or absorb your X-rays. So air has a very low attenuation value of -1000 or even less. Then soft tissues have a density that is somewhat higher than water, 20 to 45 Hounsfield units. Acute blood typically is hyperdense compared to soft tissues and water, and has Hounsfield units of 60 to 90. If we administer iodine-based contrast agents to a patient, these have a high attenuation value of 100 to 500 Hounsfield units, and one of the most hyperdense structures, or the most hyperdense structure in the body, would be the bone. The bone consists of trabecular bone, which has a somewhat lower attenuation value compared to cortical bone, because the bone is less dense there, and there is also, that's the part of the bone that contains the fatty bone marrow. And cortical bone has a very high density of more than 1000 Hounsfield units. Let's translate that information to this CT image. Here we see cerebrospinal fluid. It's very black. It has a density of 0 Hounsfield units. White matter has a higher density, of course, but is still relatively dark, has a density of about 25 Hounsfield units, and it's darker than gray matter. Gray matter is hyperdenser than white matter, with an average density of 35 Hounsfield units. And why is that? Because the gray matter contains a lot more cellular elements, the neurons, compared to white matter. White matter mainly consists of myelinated axons, contains less cells, and there's relatively more water present in white matter, decreasing its density. Then the skull has a very high density of 500 to 1000 Hounsfield units. Then we have a thin layer of subcutaneous fat in the scalp with a density of -100 Hounsfield units. And lastly, we have air surrounding the skull. Translate this information to pathology. Very basic, an acute hemorrhage is, as said, hyperdense on CT, and is an example of an acute intracranial hemorrhage. And pathology containing lots of water, let's say cerebral edema in an acute ischemic stroke, will be hypodense because it contains a lot of water, and that will decrease the density. This is a patient with an acute ischemic stroke in the territory of the left middle cerebral artery, and we see that the brain parenchyma here looks swollen and is very dark because it contains a lot of water. It's basically an area of focal cerebral edema. There are some densities that are physiological, and you should not confuse them for pathology, as sometimes happens when a young resident is on call for the very first time and is afraid to miss something. So I have seen this happen in practice. The patients are okay because nothing was wrong with them to begin with. What are typical examples of physiological hyperdensities? Well, we can often see very small calcifications in the lateral ventricles. These are choroid plexus calcifications, and we often see a nodular calcification located along the midline. This is a pineal gland calcification. You will see these very, very, very often. The older patients get, the more likely you will see them, but you can also see them in young patients already. And this is another example. These are calcifications in the globus pallidus of the basal ganglia on both sides. A very frequent finding, especially in the older population, can be a bit confusing if it's unilateral, but it can be unilateral. In this case, it's symmetrical, makes it a bit more easy, but if you just see it on one side, you might be a bit confused or think that this might be a small hemorrhage. If you doubt, do measurements or look at your bone window, but more about bone windows later. And we also see a calcification in the pineal gland and in the choroid plexus on both sides in this same patient. Now, very important when examining a CT is to master the art of windowing. What is windowing exactly? Well, we talked about Hounsfield units. Now, let's say the number of Hounsfield units or CT numbers a computer can recognize is about 2000. It's probably more, but let's say 2000. The human eye, however, because these numbers are translated in a grayscale image. However, the human eye cannot distinguish between 2000 different shades of gray. According to popular literature, 50 shades of gray is probably the maximum. And if we were to create an image of the brain, showing us all Hounsfield units from -1000 to +1000, so the density of air to the density of cortical bone, this is what that image would look like. So now we can see all Hounsfield units from very, very low to very, very high. And what do we see? Black air, a very dense, very hyperdense skull, and everything in between looks grayish. So it's impossible to recognize the structures of the brain. We cannot tell the difference between gray matter and white matter. We can barely discern the ventricles. We can see them a bit, but not as clear as we would like. So this kind of image is definitely insufficient for diagnostic purposes. So how do we solve that? Well, quite simply, we just don't visualize all CT numbers or all Hounsfield units. No, we use a window. That's what windowing is. We only display a limited number of Hounsfield unit values, and well, you have a lot of possible windows. We choose those values in such a way that it shows us the structures we're interested in the best. So the values we use for looking at the lungs, for instance, are different from the values we look for looking at the bones or looking at the brain parenchyma. I'm just talking about neuroradiology, so we're going to talk about some windows in neuroradiology. What are some concepts you should know when talking about windowing? Well, this is a window, of course, and everything that lays outside of that window will be black if the values are lower than the values in the window, and all values that are higher than the values in the window will be white. Okay, that's for starters. Then the window width is something you should know. That's basically the range of Hounsfield units that will be displayed in shades of gray. And then we have the window level or the window center, which is the central number or the middle number of all the Hounsfield units in the window width. Okay, let's apply this a bit. I'm showing you images of a brain window and a bony window, and that's what you typically get when you do a CT of the brain. Automatically, the computer sends you images in brain window and bony window. The brain window images have a high soft tissue contrast. If you look at the skull, it's just uniformly very dense, but we can clearly see all structures of the brain. We can make a difference or see the difference between white matter and gray matter. We see the deep gray nuclei, we see the ventricles, so that's a good window to look at the brain parenchyma. And then on the bone window, everything looks gray except the bone, but we can see the different components of the bone. We can see the outer layer, the inner layer, we can see the diploe containing trabeculated bone or trabecular bone rather. So this is a very good window to look for bony pathology like fractures, and it has a high bony contrast. I do not know all these values by head, but it's just an example. So for a brain window, we have a window center of 40 Hounsfield units, which is about the density of gray matter, and we have a relatively narrow window width because we only want to see soft tissue structures. In a bony window, we have, of course, a window center that's quite high and a very large window width because we mainly want to see contrast in the bony structures. You have to use both windows self-evidently. This is a patient with an intracranial hemorrhage. It's an epidural hemorrhage, and we know that these are often associated with skull fractures. However, it's impossible to recognize the skull fracture on the brain window setting of this CT scan. We have to look at the bony window, and then suddenly we see this small fracture line in the right frontal bone. Another window that you should use, but is not automatically generated, you have to create it yourself by using your mouse and windowing the image, as the so-called stroke window. And what's a stroke window? Well, it's basically windowing your image in such a way that you generate a lot of contrast between gray and white matter. And why would you do that? Because signs of early ischemic infarction can be very, very subtle. If you create a lot of contrast between gray and white matter, you can more easily pick them up. This is a brain window, and at the first glance you'd say, this looks okay to me, nothing out of the ordinary. But if there's a suspicion of ischemic stroke, window the image very, very hard. This is a typical stroke window. So the level is about the density of gray matter, 32 Hounsfield units in this case, can be 40. This is not absolute. Yeah, I never look at these values. I just create an image that looks a bit like that without really looking at what's my window width here. But it's just an example. The window width is very narrow, 8 Hounsfield units, because we want to have a lot of contrast between structures with similar densities. And if we now look at the image we created this way, the stroke window, we see that the brain parenchyma over here and the left parieto-temporal transition area looks relatively hypodense, and we cannot see the difference between gray matter and white matter. This is an early ischemic stroke. This is early edema in infarcted brain parenchyma. And if we now were to look back, oh yeah, let's first compare it with the normal side, where we clearly see a normal differentiation between gray and white matter. And if we now were to look back at our brain window image, yeah, you might already see it, but it will be, well, if you're a bit experienced, you probably pick it up, but if you're not experienced yet, definitely use the stroke window, and even experienced radiologists use your stroke window to pick up these very subtle signs of early ischemic stroke with subtle obscuration of gray-white matter differentiation and hypodensity of the infarcted brain parenchyma. Use the stroke window. Another window that's important for neuroradiologists is the so-called subdural window. This is a patient who suffered a trauma. If you look carefully in the soft tissues of the scalp, you see some swelling here and the subgaleal tissues. This is a small subgaleal hematoma. And now let's look if we see an intracranial hemorrhage over here. Maybe you've seen it, but maybe you don't. But everyone will agree that the image or the pathology is a lot more clear on this subdural window. Now, what did we do here? We see here a small left hemispheric subdural hematoma. You can also see it here, but notice that there is very little contrast between the skull and the subdural hematoma. The lack of contrast between these structures can make a subdural hematoma, if it's very small, sometimes very difficult to detect. By using a subdural window, we actually create a lot of contrast between the hematoma and the overlying skull. And what do? We use a relatively wide window width of 100 to 300 Hounsfield units and a relatively high window center. So blood has a density of 60 to 90, so that should be about the center of your window when looking for a small subdural hematoma immediately underneath the skull. So let's summarize these windows. The brain window is the classical window. That's what you start with. But if you're dealing with a stroke patient, use the stroke window. Use a window center that's about the density of gray matter with a very narrow window width. And in a subdural window, use a window center that's about the density of acute blood and use a relatively wide window width to make or generate more contrast between the skull and a small subdural hematoma. Now, a final word, and also very important, is recognizing artifacts. Artifacts are very frequent, and what do we talk about when talking about artifacts in radiology? It's basically something you see on an image, but that is not real. It's not present in the patient. It's created by the software or by an error during the making of the scan. So it's basically a false image. And it's important to be able to recognize artifacts because you should not confuse them for pathology. And these are some of the most frequent. We see here that the brain looks very blurry and also the skull. Is this a fracture over here or not? Well, very difficult to tell what happened here. The patient moved during the scan, and motion artifacts are a very frequent cause of artifacts during CT, and of course, they make interpretation difficult. The main thing is, don't call this a fracture, but on the other side, it's also difficult to with certainty rule out a fracture in a situation like this. The images are very blurry and very unsharp. Another frequent artifact is the following. Do you see all these black lines located in the cerebellum and the brainstem? This is also a very frequent artifact. These are generated by these densities over here. Oh, and there should be one on the other side as well. The patient had earrings. earrings are very, very dense structures. They basically reflect a lot of the X-ray photons, and only photons with very high energies go through them. We call those beam hardening artifacts because as only photons with high energies move through them, the beam is hardened. So a lot of energy, a relative high amount of energy, is received by the detector on the other end, and this creates these hypodense or black lines in the image. They can be seen located between two dense structures, and this is a nice example because the patient had two earrings, and notice how these lines really go from one earring to the other. But we can also see them between bony structures, which are also very dense. For instance, a typical location would be the brainstem because we have the temporal bone on both sides, and we see that there is a lot of streaking going on over the brainstem, but also in the temporal lobes, which are often also very susceptible to streaking artifacts or beam hardening artifacts. Here's another example. This looks hypodense on the axial image. You might confuse it for pathology, but if you compare it with the coronal image, we see that there is a lot of beam hardening going on between the very dense bone between the very dense temporal bone on both sides. Typical location for beam hardening artifacts, the brainstem, sometimes making the detection of a small brainstem infarction very difficult. The origin of these beam hardening artifacts is unclear to me. They might have been created by something located outside of the patient, but we see it's once again a nice example, these black lines coursing through the image, distorting the image. And you don't necessarily have to have two dense structures. Here we see a lot of black lines radiating from this central structure, and this was a coiled aneurysm. So solitary structures that are very, very dense can also create beam hardening artifacts. A final artifact you should definitely know are partial volume artifacts. This is an example of a patient who had this slightly hypodense structure located in what looks like the transition area of the right parietal and temporal lobes. But luckily, CT images are now automatically generated in multiple directions, or we get multiplanar reconstructions in the axial, coronal, and sagittal plane, and we can correlate this hypodensity with another plane, and we see that this was actually the sylvian fissure. This is what we call a partial volume artifact, which means that the density or the attenuation value given to this voxel is basically an average of all structures in that voxel. So it's a bit of cerebrospinal fluid located in the sylvian fissure, making it a bit more dark, but not as dark as fluid because it also contains a little bit of cortex. Let's summarize what are our main artifacts and do not confuse them for pathology. This brain looks very blurry, but do not call this diffuse brain edema. If it's present, it's impossible to say at the moment because the brain is so blurry because the patient moved during the scan. This also makes the detection of skull fractures or very small hemorrhages located underneath the skull very difficult. This patient had beam hardening artifacts, which are often present in the posterior fossa because it's a small space completely enclosed by bone, so very susceptible to the creation of beam hardening. And how do you recognize them? As dark streaks behind or between objects or structures of high density. And finally, a partial volume artifact, which is an artifact created by averaging the attenuation of different tissue densities in the same voxel. But this can easily be solved by looking at your other imaging planes. In this part, I'm going to discuss basic anatomy of the brain on CT, and I'm going to use an approach going from outside to inside. So I'm going to start with discussing the skull anatomy. We're going to talk about meningeal anatomy. Despite the fact that the meningeal layers cannot be clearly seen on CT, it is important to have an idea on the anatomy of the meninges of the brain. Then we're going to talk about the cerebrospinal fluid spaces of the brain, like the cerebral sulci, the ventricles, and the basal cisterns. And lastly, we're going to talk about the anatomy of the brain parenchyma, both gray matter and white matter. So let's start with the outside. Let's start with the skull. To examine the skull on a CT, it is self-evident that we have to use a bony window. And if we magnify part of the skull like this, we can clearly see the several components of the skull. We can see that the skull consists of a very thick inner layer called the inner table, a thick inner cortical layer, a very thick outer cortical layer called the outer table, and in between we have trabecular bone called the diploe. If we show you a close-up of another part of the skull, we see these lines coursing over here, or those fractures. Well, they aren't, and you will see lines like those on every CT of the skull. These are the so-called sutures. These are the places where the several bones of the skull have ossified with one another, so to say, and you can distinguish them from fractures because, well, you have the symmetry. There's often a similar line on the contralateral part of the skull, and they often have a sawtooth appearance, running a bit zigzag through the skull, and have sclerotic margins. The sutures can better be seen on three-dimensional reconstructions of the skull, and on this image we can clearly see the coronal suture. Over here we have the squamous suture, and here we have the lambdoid suture. And these sutures divide the several bones of the skull from one another. The biggest bone located between the coronal suture, squamous suture, and lambdoid suture is the parietal bone. Then we have the occipital bone at the back of the skull. The temporal bone is located at the side underneath the squamous suture, and at the front we find the frontal bone. We mostly have just one frontal bone, but in some cases there's a persistent metopic suture dividing the frontal bone in two parts. We have two parietal bones, however, and these are divided by the sagittal suture, which is best seen if you look at the skull from above. If you look at these three-dimensional reconstructions, and we are looking at the skull from above now, we see over here the coronal suture, here we have the lambdoid suture, and there is the sagittal suture, and we see two large parietal bones on each side of the sagittal suture. So that concludes the discussion of the skull. Let's move inside. Immediately underneath the skull, we find meninges. And what are the meninges? These are very thin membranes covering the brain. We have the very thick dura mater, which is a very thick meningeal layer closely opposed to the skull, and it folds inwards, forming the falx cerebri. And in the falx cerebri, both at the back and at the front, we find the superior sagittal sinus. Immediately underneath the dura mater, we have a thin meningeal membrane, the arachnoid. The arachnoid is closely connected to the dura mater and follows the contours of the dura mater, so it does not run inside the sulci. That is something the pia mater does, which is the thinnest meningeal layer, and is immediately located above the brain surface following the morphology of the cerebral gyri. Between the arachnoid and the pia mater, we have a space containing cerebrospinal fluid called the subarachnoid space. In this space, we have, as said, cerebrospinal fluid, but we also find arteries and veins and some kind of trabecular connective tissue meshwork connecting the arachnoid with the pia mater. Everything that stands or is written on this slide has already been said. So we start with the very thick dura mater immediately underneath the skull. Then we have the thin arachnoid mater in close contact with the dura, and the pia mater located immediately above the brain surface. If we look on these images, we can see one specific meningeal structure. So most of the meninges cannot be seen on CT of the brain, except for the falx and the tentorium. Now, what is the falx? We see this very thin, slightly hyperdense structure running in the longitudinal fissure of the brain. This is the falx cerebri, and the falx cerebri is, as already said, an infolding of the dura mater along the midline in the interhemispheric or longitudinal fissure. We can also see it on these images a couple of slices lower, and notice these somewhat triangular structures located in front and at the back of the falx. These contain the superior sagittal sinus, which is surrounded by dura and located inside these dural layers. So superior sagittal sinus. Then we have a second dural layer that can be seen on CT, and that is the tentorium. The cerebellar tentorium is an infolding of the dura mater, basically separating the brainstem and cerebellum located underneath it from the occipital lobes of the cerebral hemispheres and the rest of the brain. So the tentorium cerebelli is a bit tent-shaped, but has an opening called the tentorial notch. And this opening is made, or this is an opening for the midbrain. And it's an important opening because, as we will see when we talk about brain herniation, in cases of increased intracranial pressure, or when there's a space-occupying lesion located in the supratentorial brain compartment, this can lead to herniation of brain parenchyma through the tentorial notch, causing compression of the brainstem. On this coronal image, we can see both the falx and tentorium, and we see that these are connected with one another or continuous with one another. The falx cerebri is located in the midline in the interhemispheric fissure and separates the right from the left cerebral hemisphere. Then we have the tentorium cerebelli, which separates the cerebellum from the occipital lobes of the cerebrum. Now let's move on to the cerebral sulci. We are now talking about the cerebrospinal fluid containing spaces of the brain, and the cerebral sulci belong to those spaces. What are the sulci? Well, let's first answer the question about the gyri of the brain. If you look at the brain surface, it is not smooth. The brain has a very convoluted appearance because it consists of folded cortical tissue, and the cerebral cortex is folded because, due to this folding, the brain surface area is exponentially increased. So we have a lot more room for cerebral cortex this way. These folds or ridges are called gyri, and sulci are clefts or furrows filled with cerebrospinal fluid surrounding the gyri. If we have very deep or important sulci, we call those fissures. And there are two fissures you should definitely know. The first one would be the Sylvian fissure, and the Sylvian fissure can be seen over here. It is the fissure separating the frontal and the parietal lobe from the temporal lobe. And over here we find the insular cortex underneath the Sylvian fissure. A second very important fissure is the interhemispheric fissure. The interhemispheric fissure is the fissure separating both cerebral hemispheres containing the cerebral falx, a structure we already talked about. This is the Sylvian fissure in the sagittal plane, and we clearly see how it separates the frontal lobe and parietal lobe from the temporal lobe located underneath it. There are a lot of sulci in the brain, and there is a separate video on this channel discussing cerebral cortex anatomy, in which the anatomy of the cerebral gyri and sulci is discussed in great detail. Now, definitely check it out. It's less than an hour long, but needless to say, I won't discuss cerebral sulcal and cortical anatomy in detail in this video. Just believe me when I tell you that this is the central sulcus, which separates the frontal lobe from the parietal lobe, and over here we once again see the Sylvian fissure with the temporal lobe located lateroinferiorly from it. Here we see the base of the frontal lobes, or the basal aspect of the frontal lobes, and here we have the occipital lobes at the back. There are several sulci and fissures which separate these brain lobes from one another, but at other places these do not exist. For instance, there is no sulcus clearly separating the temporal lobe from the occipital lobe. So if you have a lesion in this region, it's definitely not wrong to call this the temporo-occipital transition area, for instance, because there simply isn't a clear border between these two brain lobes. Let's now talk about the ventricles, which are cerebrospinal fluid hollow spaces located centrally within the brain. And we have 4 of them. We have 2 lateral ventricles, as you can see here, and running in the middle between both lateral ventricles is a very thin membrane called the septum pellucidum. We also see that there are soft tissue structures located in the lateral ventricles. This is choroid plexus, and choroid plexus is responsible for producing cerebrospinal fluid. On this image over here, we clearly see the lateral ventricles, and we also see calcified plexus located in the trigone of both lateral ventricles. And then we have a new structure, the third ventricles, with on both sides the thalamus. The third ventricle, or the third ventricle, communicates or is continuous with lateral ventricles through a small opening, well, basically 2 small openings called the foramina of Monro. Let's first look at the coronal image, this one over here. Here we see the frontal horns of the lateral ventricles, and this is the third ventricle. The small opening connecting them is called the Monro foramen, as indicated by the arrows over here. And we can also see it on the axial image, of course. But let's magnify it to make it a bit more clear. Here we have the septum pellucidum, and this somewhat nodular appearing thickening are basically the 2 fornices. The fornix is a white matter tract which runs along the inferior surface of the septum pellucidum and connects the hippocampus with the mammillary bodies, or with the ipsilateral mammillary body. It's not that important, just so you know what this structure is. And here we see the Monro foramen connecting the lateral ventricles to the third ventricle. This is an important region to examine in a patient with hydrocephalus, because in a patient with hydrocephalus, it's important to look for the cause of the hydrocephalus. There are many potential causes, but an obstruction of the cerebrospinal fluid circulation can be one of them. And that obstruction is most likely to occur at those passageways that are the most narrow, like the Monro foramen between the lateral ventricles and the third ventricle. The last ventricle we need to discuss is the fourth ventricle, located infratentorially. We can clearly see it here on the axial image between the brainstem and the cerebellum, and also on this sagittal image. Once again, we have a very narrow passageway connecting the third ventricle, located over here, and the fourth ventricle. And this is the cerebral aqueduct. This plate you can see posteriorly from the cerebral aqueduct is the tectal plate, containing the superior and inferior colliculi. The cerebral aqueduct is sometimes also called the Sylvian aqueduct, and is also one of the areas you definitely need to scrutinize in a patient with a hydrocephalus to exclude an obstruction at this specific point. What are the basal cisterns, or what are cisterns? Well, we talked about the subarachnoid space. When the subarachnoid space is very wide, not pathologically wide, physiologically, but very, very wide, we call that a cistern. And we mainly find cisterns in the basal brain area. There are a lot of them. I'm not going to discuss the terminology of each and every cistern there is in the brain, because in daily radiological practice, you don't really need an information. Very important are these, located at the level of the mesencephalon. I magnified this a bit. This one looks a bit like a Star of David and is, as a consequence, called the pentagonal cistern. This is not a correct anatomical term. This is basically a collection of several cisterns, but because combined they have this particular shape, we call them the pentagonal cistern. And the cisterns located around the mesencephalon or the perimesencephalic cisterns. Why did I single these out? Because if a patient has a brain herniation through the tentorial notch, something I already talked about, the basal cisterns will become narrow or even completely effaced. So this is also an anatomical region you definitely need to inspect on a CT of the brain. Let's move on and let's now talk about the brain parenchyma. The brain parenchyma consists of two major components, gray matter and white matter. And when gray matter is located at the surface of the brain, we call it cerebral cortex. The cerebral cortex is the layer of gray matter which is organized in folds or gyri along the brain surface, and it contains the neurons. Because it contains more cells than white matter, it is relatively hyperdense compared to white matter. The white matter is located underneath the cerebral cortex. It contains for the most part, myelinated axons of the neurons. It contains less cellular elements, and as a consequence, a bit more water and is a bit more hypodense compared to gray matter. It's very important you see that difference. You see the difference in density between the cortex and the white matter. We call this the gray-white matter differentiation. And if it is absent, it is a sign. If it is absent, it is a sign of pathology. But more on that when we talk about pathology. When it comes to gray matter, I talked about the cerebral cortex, located on the brain surface, organized in folds or gyri, but we also have islands of gray matter located deep within the brain parenchyma. We call those deep nuclei, collection of gray matter structures deep within the brain. And there are a few you should know because they are visible on a CT of the brain. Let's magnify this image a bit. They are located in the region of the lateral and third ventricles, and we can recognize three structures. This is the head of the caudate nucleus. This lens-shaped structure is the lentiform nucleus, consisting of two nuclei, the putamen and globus pallidus, but we are not able to distinguish them on a CT of the brain, and this is the thalamus. The caudate nucleus and lentiform nucleus belong to the so-called basal ganglia, a group of deep gray matter structures which play, amongst others, a role in movement in the extrapyramidal symptom. So, if you have a lesion in the basal ganglia, this can lead to movement disorders. The thalamus, on the other hand, does not belong to the basal ganglia, but is a structure, basically a collection of nuclei, more than 100, 130, I believe. It is basically a relay station for the brain. All information that enters and leaves the brain at one point goes through the thalamus. Well, not all information, but let's say most of the information. And the thalamus has a tendency to kind of modify it a little bit and direct it and send it in the right direction. And if you looked carefully at the previous image, you will have seen that between these deep gray matter structures, there was also white matter present. This white matter, which has the shape of an angle, is called the internal capsule. The internal capsule is not one white matter tract, it's basically a very concentrated collection of white matter tracts, making it a very important structure. If I magnify this a bit, you can see that the internal capsule has two components. It has a posterior limb located between the lentiform nucleus and the thalamus, and it has an anterior limb located between the head of the caudate nucleus and the lentiform nucleus. And the point where they meet is called the genu, or the knee of the internal capsule. When it comes to the rest of the brain, well, when it comes to white matter anatomy, you really need diffusion tensor imaging to visualize the separate tracts. There is the white matter tracts of the internal capsule have a tendency to fan out at the superior level to the rest of the brain. And this fanning out of white matter is called the corona radiata. So it's basically a gathering of white matter tracts connecting the internal capsule with the rest of the brain. And the centrum semi-ovale is basically a term that is given to the white matter bulk, as you can see it on imaging at the level above the lateral ventricles. So the corona radiata cannot really be discerned separately on a CT of the brain, but it is roughly located in the periventricular white matter along the lateral ventricles above the level of the internal capsule and underneath the level of the centrum semi-ovale. And something we can also see on this image is the white matter of the corpus callosum. The corpus callosum is the white matter tract connecting both cerebral hemispheres and is basically better seen on sagittal images. On this mid-sagittal image of the brain, we see the corpus callosum over here. It is very thick and is basically the thickest white matter tract, basically a white matter commissure connecting both cerebral hemispheres. It consists of a genu, a truncus, and a splenium, and this small triangular shape over here is called the rostrum. We're almost through with our discussion of brain anatomy on CT. Maybe I'd just like to point your attention to the pituitary gland, located over here, best seen on a mid-sagittal CT image and located in this depression in the sphenoid bone called the sella turcica. We haven't really talked about the infratentorial structures, the brain structures located underneath the cerebellar tentorium. I'm just going to do it very briefly because here is the tentorium cerebelli. What we find there is the brainstem and the cerebellum. The brainstem has several components. Let's look at the sagittal image. Posteriorly, we have the cerebellum. And then when it comes to the brainstem, we can recognize the superior midbrain. Then we have the pons, and finally the medulla oblongata connecting the brainstem with the cervical spinal cord. Now that we know the basics of CT and CT interpretation, as well as standard brain anatomy, we are ready to dive into brain pathology on CT. Hello and welcome in this final video on how to read a brain CT. In the first two videos we talked about the basic principles of CT, how a CT image is generated, what are the basics of CT interpretation. In the second video I talked about brain anatomy on CT, and now finally we can talk about brain pathology. Of course, I'm not going to talk about every pathological entity out there, but the most common ones or the most frequently asked ones from your referring physicians. Needless to say, CT is often the first examination performed in trauma patients or in patients with acute neurological symptoms, so the emphasis will be on that kind of pathology. Well, when you do a search for pathology on your CT, you can start with a very quick check. So before trying to discover subtleties, I do a quick check, namely, is the midline normal? Is there a normal position of the midline? Because if there isn't, that already indicates the presence of a space-occupying process somewhere. Is there a normal differentiation between gray and white matter? I told you that the densities of gray matter and white matter are different, and they should be different. If you can no longer distinguish or make the difference between gray and white matter, you're probably or possibly dealing with subtle edema and a sign of early ischemic infarction or an early sign of ischemic infarction. Look at the size of the ventricles to rule out hydrocephalus, or if they are narrowed, to rule out a space-occupying process narrowing the ventricles. Also look at the basal ganglia. For the same reason, you should check the gray-white matter differentiation. The basal ganglia are gray matter structures, so you should clearly see the difference between these gray matter structures and the surrounding white matter of, for instance, the internal capsule. If you don't, you are possibly dealing with edema and possibly with ischemic infarction. And lastly, look at the basal cisterns. These should be open. If they are compressed or effaced, you are also possibly dealing with a space-occupying lesion causing transtentorial brain herniation. Okay, these are just some quick rules to immediately look for something urgent. Now let's talk about several entities in a bit more detail. Keep in mind it's going to be a short presentation, so it just covers the basics. It's just to get you started. I'm going to talk about acute ischemic stroke, brain hemorrhage, hydrocephalus, and brain herniation. We're going to start with acute ischemic stroke. What is a stroke? Well, basically, rapidly developing clinical signs of a focal or global disturbance of cerebral function lasting more than 24 hours or leading to death, with most likely with no apparent cause other than of vascular origin. Okay, that's quite a mouthful. This is the definition by the WHO that is still widely used nowadays. What does this mean? In easy terms, well, basically, it means an ischemic stroke is caused by an obstruction of blood flow to a certain part of the brain, causing that part of the brain to become necrotic, to die. And as you can see on this image, this is an established infarction. We see that the brain becomes edematous and swollen, making it become very dark on a CT image. It is important to know your arterial territories to recognize an ischemic infarction on a CT image, because if an artery is occluded, only the part of the brain that is supplied by that specific artery will infarct, and only in that part of the brain will you see signs of ischemic infarction. What are the main arterial territories of the supratentorial brain? We have the territory of the middle cerebral artery, which is the biggest territory, composing most of the lateral part of the cerebral hemisphere. And if you have a stroke in the middle cerebral artery territory, patients will present with a contralateral hemiparesis affecting the arm more than the leg. And if the stroke is located in the left hemisphere, patients will generally present with aphasia. If the anterior cerebral artery territory is located anteriorly along the medial surface of the cerebral hemisphere, and a stroke in that territory can lead to a contralateral hemiparesis with the leg more involved than the arm. Lastly, the posterior cerebral artery territory is located at the back and the medial surface of the cerebral hemisphere. This contains the primary visual cortex, so patients, when having a stroke in that area, will present with contralateral hemianopia. Now that we know the vascular territories, it is easy to see an established infarction in those respective territories. Established meaning that the infarction is already at least a couple of hours, maybe even a couple of days old. And in an infarction of that age, the infarcted area will become very swollen and very hypodense. You're basically looking at tissue that is infarcted, it is dead, and it has turned the entire brain area into an area of brain edema. Here we see a patient with a large established infarction in the territory of the left middle cerebral artery. This is a patient with an established infarction in the territory of the left anterior cerebral artery. And lastly, a patient with an infarction in the posterior cerebral artery territory on the left side. Now, the thing is, if a patient has an established infarction, there is nothing that can be done anymore. The goal of imaging is to basically detect patients at an early stage, so when they are still eligible for therapy. And in that stage, the signs of infarction can still be subtle. This is a patient with a large left middle cerebral artery territory infarction, but at a first glance, you really have to look carefully at these images. The midline seems okay, but there's an asymmetry between the lateral ventricles. Mind you, a slight asymmetry can occur in the general population, but it can also be a sign of a space-occupying lesion. In this case, it's not a tumor, it's not a hemorrhage, no, it's brain edema. And although the edema is not as conspicuous as on the previous cases, look carefully. Look if you can see the gray-white matter differentiation in the left cerebral hemisphere. You can't. The gray-white matter differentiation is gone. This is cerebral edema in the territory of the left middle cerebral artery, and this was an early total media infarction. In some cases, the infarction can be located in the territory of a smaller, more peripheral artery. In that case, self-evidently, not the entire territory of the middle cerebral artery or one of the other main arteries of the brain will be involved, but only part of the brain. Here we see a hypodense region located in the left frontal lobe with absent gray-white matter differentiation. This was an early partial media infarction due to occlusion of a branch of the left middle cerebral artery. When looking for signs of infarction, it's important to look for loss of gray-white matter differentiation. Because there is edema, there can be sulcal effacement, and the abnormalities or the region of edema will be hypodense, although this can be very discrete in an early phase. We talked about the stroke window in an earlier video. We'll definitely use it to look for subtle edema in an early infarction. Here's another patient. Does this patient have signs of infarction? At a first glance, we might say, looks okay, but let's window this a bit. Let's use a stroke window. Now, these images are hard to look at, they almost hurt the eyes, but if we now look carefully at the region of the left basal ganglia, what do we see? The lentiform nucleus, clearly seen on the right side, is missing on the left. And there is no differentiation between the cortex of the left insula and the underlying white matter. So these are definitely signs of early infarction, or early signs of infarction rather. And if we now look back at the brain window, yeah, we could have seen it there as well, but it's easier if you use a strong stroke window. The disappearing of the basal ganglia is called the disappearing basal ganglia sign, and you should definitely always check your basal ganglia in a patient suspected of having an ischemic stroke, especially if the patient has symptoms that would fit a middle cerebral artery infarction. And I already mentioned it, also look at your insular cortex. Let's examine these images. Let's magnify them a bit. What do we see? The left lentiform nucleus is missing again, at least partially. We can clearly see it on the right side. On the left side, maybe here there's something left, but the rest is dark. But what is missing as well? The cortex of the left insular ribbon, or the left insular cortex rather. Clearly seen on the right side, absent on the left. This is an insular ribbon sign, or absent insular ribbon, and is also a sign of early infarction. A last sign you should look for is a dense artery sign. Sometimes the thrombus can be visualized on unenhanced CT images, and a thrombus, consisting of clotted blood, will be very bright or hyperdense. However, be careful. It's nice if you see a dense artery sign, but you will still have to do a CT angiography and keep in mind that there are many false negatives. You can, or many, yeah, there are many false negatives because you only have a hyperdense artery sign in 30% of cases, and you can also have false positives. For instance, if a patient has ateromatosis of the main branch of the cerebral artery, for instance. So this sign does not obviate you from the need to do a CT angiography. Let's move on to brain hemorrhage. I told you these would be very short presentations. An acute hemorrhage is hyperdense. The word acute is very important here because as a hematoma ages, it will gradually liquefy and be resorbed by the body, and it will gradually become more hypodense. So in this presentation, I'm talking about acute hemorrhages in the brain, and they will all be hyperdense on the CT images I am showing you. When seeing a brain hemorrhage, so if you see a hyperdense abnormality, chances are it's a hemorrhage. What is important in a hemorrhage? That you localize it accurately. You localize it as being either inside of the brain or outside of the brain. And if it's outside of the brain, you have to try to determine in which meningeal compartment it is located. Is it a hematoma in the epidural space, an epidural hematoma, a subdural hematoma, subarachnoid hemorrhage, maybe a ventricular hemorrhage? And when it comes to the deep hemorrhages located inside the brain parenchyma, you can also make a distinction which will have implications for the differential diagnosis between a parenchymal hematoma located in deep structures and a parenchymal hematoma located superficially in the brain, a so-called lobar intraparenchymal hematoma. Let's examine these various hematomas or hemorrhages one at a time. Let's start with an epidural hematoma. An epidural hematoma is a blood collection located between the skull and the dura. I drew the dura for you, and you can see that this hematoma is located between skull and dura. Of course, in a normal situation, you cannot recognize the dura on a CT. So how can you tell this is going to be an epidural hematoma? Well, basically, mainly based on the shape of the hematoma. So what can a epidural hematoma never do? It cannot cross the sutures. Why is that? The hematoma is located between the skull and the dura, but the dura is very firmly attached to the skull at the level of the sutures. It is so firmly attached that a hemorrhage cannot pass it, unless a fracture line were to pass through the suture. In that case, it can. So, because it cannot cross the sutures, it cannot expand any further along the brain surface and will expand, how am I going to say this? It will expand in this direction. Look at my arrow, I can't find the word, giving the hematoma a typical lens shape or a convex shape. And this is very characteristic. What is also very typical for the epidural hematoma, they are almost always traumatic, and in the majority of cases, more than 90%, you will find a skull fracture in the overlying skull. And the hematoma is caused by a laceration of an artery running along the inner surface of the skull. So, how can I tell this is an epidural hematoma? Because it has a very typical convex shape, a typical lens shape. It seems to stop at the level of the coronal suture and the lambdoid suture, and an epidural hematoma cannot cross the sutures. And let's just pretend that I have also a bony window, which clearly shows a fracture line here. Well, these are all signs of epidural hematoma. A subdural hematoma can look a bit similar, but not quite. In most cases, you can clearly tell the difference. A subdural hematoma is located between the dura and the arachnoid, so it's located underneath the dura. And it can cross the sutures, but it cannot cross the midline, which makes sense because the dura will fold inwards along the midline. And because the hematoma is located underneath the dura, it can never cross the midline, self-evidently. So the arachnoid we cannot see, but just imagine this is the arachnoid over here. Because the hematoma can spread along the entire cerebral hemisphere and even further along the falx, for instance, it will never adopt the typical lens shape we have seen in an epidural hematoma and will be more crescent-shaped, often with a concave inwards border. These hematomas are mostly traumatic, but especially in elder patients, the trauma can be very minor, and in a lot of cases, patients cannot remember they had an accident. Well, when talking about older patients, that is. A subarachnoid hemorrhage is a hemorrhage located in the subarachnoid space. And the subarachnoid space, of course, well, the sulci or subarachnoid space, so it is clear that blood in the subarachnoid space will follow the contours of the sulci and or the basal cisterns. Subarachnoid hemorrhages are seen in a lot of traumatic brain injuries, so they can be traumatic. They can also be spontaneous, and if you're dealing with a spontaneous, a non-traumatic subarachnoid hemorrhage, your main worry should be if the patient has a cerebral aneurysm and CT angiography should be performed. Can you tell the difference, or can you predict if a hemorrhage is going to be traumatic or caused by an aneurysm? Nothing is 100%, but in a traumatic subarachnoid hemorrhage, most cerebral aneurysms are located at the base of the brain, so that is where you will find most subarachnoid blood. An aneurysmal subarachnoid hemorrhage will mainly, the subarachnoid blood will mainly be located in the basal cisterns and less along the cerebral hemispheres. This is a typical pattern as can be seen in a ruptured cerebral aneurysm. In a traumatic subarachnoid hemorrhage, the blood can basically be located anywhere, but the predominance of blood in the basal cisterns will often not be present. In this patient, the blood was mainly located along the right cerebral hemisphere, but there was no blood in the basal cisterns, which is very unlikely for a ruptured aneurysm. Furthermore, the patient also had a subdural hematoma along the left side, making this a pretty easy case. This was a traumatic subarachnoid hemorrhage and also subdural hematoma. Let's move on to hemorrhages or hematomas located inside the brain parenchyma. So these can be traumatic and spontaneous. When intraparenchymal hematomas are traumatic, they often have a predilection for the cortex of certain brain areas along the base of the brain. Spontaneous hemorrhages tend to often be either deep inside the brain parenchyma, but can also be superficial. And in that case, we call them lobar intracerebral hemorrhages. And as said, brain contusions are seen after trauma. This is what brain contusions typically look like. We see these very small patchy hemorrhages, somewhat surrounded by edema, located at the base of the frontal lobes and also anteriorly in the temporal lobes on both sides. There is associated subarachnoid blood, some subdural blood. I admit it is not so easy on these images, so just believe me. And this is basically some kind of traumatic brain bruise. This occurs following an acceleration-deceleration injury of the head, causing the brain to slide over the bony ridges of the anterior cranial fossa and against the middle cranial fossa. The locations are quite typical, although basically contusions can occur anywhere, but these are definitely predilection sites. They are often patchy, you often have multiple, often surrounded by edema, and there is often local subarachnoid hemorrhage present. These are two patients with spontaneous intraparenchymal hemorrhages. In elder patients, if you have a spontaneous intracerebral hemorrhage located deep within the brain, in the region of the basal ganglia for instance, it is very likely going to be a hypertensive hemorrhage. Also notice that this hemorrhage has ruptured into the ventricular system. If you have an intraparenchymal hemorrhage located superficially in the brain, a so-called lobar intracerebral hemorrhage, in an elderly patient, it is very likely that it is going to be secondary to so-called cerebral amyloid angiopathy, which is a disease causing weakening of especially leptomeningeal and cortical arteries due to the deposition of a certain protein, amyloid proteins, in the vessel wall. Primary hypertensive hemorrhages are, as said, mostly found in deep brain structures, and predilection sites are the basal ganglia, the thalamus, the brainstem, and also the cerebellum. If you see a spontaneous intracerebral hemorrhage in an elderly patient, chances are the patient has chronic hypertension, and this is a primary hypertensive hemorrhage. Let's summarize hemorrhages. I've shown you the several kinds of hematomas you can encounter on CT imaging based on their location. We have seen epidural hematomas, which have a typical lens shape and cannot cross sutures. We have seen subdural hematomas. Oh yeah, they have a convex inner border. We have seen subdural hematomas, which are crescent shaped, follow the dural contour or the surface of the cerebral hemisphere. They cannot cross the midline, however, and subarachnoid hemorrhages, which are located inside the sulci and follow the sulcal anatomy. We have also seen intraparenchymal hematomas, brain contusions, often very patchy and located at typical locations such as the base of the frontal lobe and the temporal pulse. And we have seen deep intracerebral hemorrhages, which are often hypertensive in elderly patients, and lobar intracerebral hemorrhages, which are often secondary to cerebral amyloid angiopathy in elderly patients. The cause can be traumatic or spontaneous, but epidural hematomas are almost always traumatic, as are most subdural hematomas. Subarachnoid hemorrhage can be both, but we have seen the difference between the pattern of an aneurysmal subarachnoid hemorrhage and a traumatic subarachnoid hemorrhage. Ventricular hemorrhages can be traumatic or spontaneous, and we have contusions. When it comes to spontaneous hematomas, we have the subarachnoid hemorrhage due to a ruptured cerebral aneurysm, and we have our parenchymal hematomas, either deep or lobar. Let's talk now about brain herniation. What is brain herniation? Well, the brain is, or the skull rather, is a closed box, holding the brain, surrounded by cerebral spinal fluid and vascular structures. It has a fixed pressure, so as soon as you have a space-occupying lesion causing an increased intracranial pressure, you will get a shift from brain structures from their normal location, and that is called brain herniation. There are several types of brain herniation, but I'm only going to show you two of them, but they are the two most important and frequent ones. You can have herniation of brain tissue underneath the falx, and this is called subfalcine herniation. This here is an epidural hematoma causing a shift of the brain parenchyma to the other side, and it presses the ipsilateral brain parenchyma underneath the falx to the underside. Then we have another structure, the tentorium cerebelli. I have told you about the tentorial notch, the opening anteriorly of the tentorium for the midbrain. If you have a space-occupying lesion supratentorially, this can cause herniation of brain tissue through the tentorial notch, and this, if it is unilateral, is called uncal herniation. But if the herniation occurs bilaterally or from central in the brain, it's called transtentorial herniation. Now, the most important thing for us as radiologists is be able to recognize them. Here I'm showing you two patients with deep intraparenchymal hematomas. And what do we see? We see a clear shift of the midline, which is a sign of subfalcine herniation. Let's draw a line. We can suspect where the falx cerebri would insert, both anteriorly and posteriorly. Let's draw a line along that virtual line in this case, and let's see where the midline structures of the brain, like the septum pellucidum, are now located. These are clearly deviated towards the other side. So we have a space-occupying intraparenchymal hematoma located in the right cerebral hemisphere, causing a subfalcine herniation to the left. This is a very important thing to notice as a radiologist, to report or to even, not just write it down in your report, call your neurosurgeon or your emergency physician right away, because this is extremely important. How do you measure a midline shift? There are several ways you can do it. The easiest one for me is draw a line along the course of the falx, or where the falx should normally be located. Locate a certain midline structure, often the septum pellucidum, and see if there is any deviation. In this case, there isn't. In this case, quite obviously, there's a deviation to the right side. So that's how I measure it, but in the literature you'll find other methods. Another kind of herniation, well, not right away. What do we see in this patient? Clearly something is going on in the right cerebral hemisphere. We have here a large space-occupying lesion, and this was a glioblastoma, a very malignant tumor of the brain. It is surrounded by hypodense brain edema, and notice how the cortex is not involved. The cortex is not involved by the edema. This is a sign that we are not dealing with an ischemic infarction, because in an ischemic infarction, we would have loss of the gray-white matter differentiation. But that's not so important right now. We are going to talk about herniation. What do we see? Let's draw a line along the presumed course of the falx cerebri, and we see that the septum pellucidum is located here. Also notice the narrowing of the right lateral ventricle, and there's a clear shift of the midline to the left side. This is a left-sided subfalcine herniation, or a subfalcine herniation to the left, rather. Let's take a look at another slice in the same patient. Here is the tumor surrounded by edema. What is this? This is the mesencephalon, or the midbrain. But the morphology is not normal. Why is that? Because it is compressed. And do you know what this is? This is the uncus of the temporal lobe. This is an uncal herniation causing compression. So the right mesiotemporal brain structures are herniating through the tentorial notch, causing compression of the midbrain. This causes narrowing and effacement of the basal cisterns, flattening of the mesencephalon, and a deformation of the normal morphology of the mesencephalon. Let's look at it in the sagittal plane. If we look at the sagittal plane, or let's look in the coronal plane, we can clearly see the tumor located over here. This is edema, and we see here the tentorium. I'm going to remove these. Yes, can you see it? These very faint, dense lines. And we see that the brain parenchyma is herniating over the tentorium on the right side. In the mid-sagittal plane, we would normally expect to see third ventricle over here. Instead, we see part of the tumor causing compression of the surface of the midbrain. Let's talk about hydrocephalus, and this is the final topic of today. What is hydrocephalus? It's an increased amount of cerebrospinal fluid in the ventricles, causing or associated with increased intracranial pressure. It can be communicating or non-communicating, and the main differential diagnosis, especially in the elderly population, would be with enlarged ventricles secondary to cerebral atrophy. But the difference is actually not that difficult. Let's compare these two patients. Which patient has hydrocephalus? I think anyone will agree that it is the patient on the left side. We see clear widening of the ventricles, but let's look at the sulci. These are completely effaced. This is because there is increased intracranial pressure due to the hydrocephalus, causing effacement or compression of the cerebral sulci. In patient number 2, however, we see widening of the ventricles, but we see a lot of atrophy and also tissue loss generalized because this was a patient who suffered a severe hypoxic ischemic encephalopathy causing generalized cerebral damage and cerebral atrophy. Notice that the ventricles are widened, but the sulci are very open and not narrowed at all. So this is what we could call an ex vacuo or a passive ventriculomegaly secondary to tissue loss or atrophy. When it comes to hydrocephalus, the ventricular size is disproportionate compared with the sulcal width on CT images. So if you have large ventricles and the sulci are completely effaced, you should definitely consider hydrocephalus. And then the next question is, what is causing the hydrocephalus? To answer that, try to determine if it's a communicating or non-communicating hydrocephalus. Let's take a look here. We clearly have widening of the lateral ventricles, clearly seen also on the sagittal plane, as well as widening of the third ventricle. I have told you that if you're dealing with hydrocephalus, look at the outlets or the narrow passageways. Now, the foramen of Monro cannot be involved because we have both widening of the lateral ventricles of the third ventricle. Let's look at the cerebral aqueduct. Can't be seen. Why not? Well, first of all, because there is compression of the cerebral aqueduct, no communication is possible between the third ventricle and the fourth ventricle, so we are dealing with a non-communicating hydrocephalus. And the hydrocephalus is caused by a large pineal gland tumor compressing the cerebral aqueduct. Here's another example of a patient with a hydrocephalus. We see clear widening of the ventricles, massive widening with complete effacement of the cerebral sulci, but also notice that there are periventricular hypodense white matter changes. This reflects edema. Water is basically compressed from the ventricles into the brain parenchyma due to the increased pressure in the ventricular system. And that is what that would look like on a FLAIR image. This is the same patient, and this is transependymal edema. Water being pressed from the ventricles into the periventricular white matter. And can you see the cause? We clearly see massive widening of the temporal horns of the lateral ventricles and the third ventricle. Is this fourth ventricle? No. This is fourth ventricle, and this is a tumor compressing the fourth ventricle. This was a tumor in a child. I cannot remember which one it was, if it was a medulloblastoma or something else, but whatever the cause, this patient had a non-communicating hydrocephalus due to an obstruction at the level of the fourth ventricle by a tumor. This is a 32-year-old female patient. Does she have hydrocephalus? The ventricles look a bit widened, one must say, and the sulci cannot clearly be discerned. It is a young patient. In young patients, it's normal to not see much sulcal widening, but still, if you are in doubt, there's one thing you should look at. Look at the temporal horns. The temporal horns are the most sensitive to early changes or to widening in hydrocephalus. They are often the first component of the lateral ventricles to dilatate if a patient develops a hydrocephalus. So always check your temporal horns. In young people, these should be very flimsy. If they look swollen like this, something is clearly off, and this is a hydrocephalus. And what is the cause? Well, lateral ventricles, third ventricle, basically septum pellucidum, but never mind, third ventricle, fourth ventricle, cerebral aqueduct looks open. This is a communicating hydrocephalus because all ventricles can communicate with one another. The foramen of Magendie looks open. So where's the compression? Let's look at the MRI image. So this is a communicating hydrocephalus due to a tuberculous meningitis. Do you see this structure located in front of the brainstem? This was a basal meningitis due to tuberculosis. Okay, we're almost through. Then there are some other pathological entities I think are important to know as a radiologist. This is a patient in status epilepticus, had fever, and what do we see? Well, we see a lot of artifacts, making this very difficult, but nevertheless, the right temporal lobe is very bothersome. And if you see temporal lobe edema in a patient that is acutely ill with seizures, fever, and so on, definitely consider herpes simplex encephalitis, which was the case in this patient. So temporal lobe edema in an acutely ill patient, always, always, always consider herpes simplex encephalitis. Here's another example of a young woman who was brought to the ER because of status epilepticus, and we clearly see edema involving the left temporal lobe, both on the axial image and on this coronal image. This was also herpes encephalitis, and here it is more subtle, but look very closely. 64-year-old man found at home, drowsy. We see that the right mesotemporal region is very hypodense, both in the axial images as on the coronal images. Compare the right hippocampus with the left one, it's clearly swollen and hypodense. This was another example of herpes encephalitis. This is a patient with diffuse brain edema, a 4-year-old boy who was found and suffered an incident, but I cannot really remember what it was, but whatever it was, it caused massive brain edema. This was a hypoxic ischemic encephalopathy. We see that the brain parenchyma is diffusely hypodense. There is complete sulcal effacement. The lateral ventricles are completely narrowed and there is no gray-white matter differentiation whatsoever. The only thing we see is that the cerebellum is spared and looks relatively bright compared to the swollen brain parenchyma above it. And this is called the bright cerebellum sign, but is definitely not always present, and the cerebellum can also be involved. So this is what diffuse brain edema looks like, as can be seen following a severe hypoxic ischemic incident, for instance, a drowning, a cardiac arrest, strangulation, or something else. Last case, this is a woman who developed seizures shortly after giving birth. And what do we see? Oops. We see hypodense changes in both occipital lobes. The cortex is spared. They are located in the subcortical white matter. You could say, could these be bioccipital infarctions? But then it is strange that the cortex is not involved. This was PRESS. PRESS, posterior reversible encephalopathy syndrome. It's a syndrome characterized by often occipital or parieto-occipital edema mainly located in the watershed areas of the brain, and which can be seen in association with a variety of clinical situations such as malignant hypertension, acute kidney failure, certain medications such as chemotherapy, and also following delivery or in cases of eclampsy or pre-eclampsy. So if you see a bioccipital edema and it's not an ischemic infarction, think PRESS, especially if there's a clinical situation that would fit that diagnosis. Okay, this was a long presentation. Always difficult to find good key messages if the presentation was long, but I'm going to try. What do I think is very important? Well, that you know brain anatomy and so on goes without speaking, but that you are aware of your artifacts. Know your artifacts, recognize motion artifacts, beam hardening artifacts, and partial volume artifacts so that you avoid mistaking them for pathology. The second one is use windows, because you can just look at your brain window, but if you do that, you will miss skull fractures. So look at the bone window for that. And you can miss signs of early infarction or early signs of infarction. If you don't use a stroke window, you can miss a subtle subdural hematoma if you don't use a subdural window. So learn how to window, know how to window, and window the shizzle out of your images. The last message, or the last message, know what to look for when dealing with a patient suspected of having an acute ischemic stroke. Know your signs or early signs of stroke, like the disappearing basal ganglia sign or the disappearing insular ribbon sign. And last message, never miss one of these: hemorrhages, and localize them correctly, hydrocephalus, brain herniation, and when dealing with temporal lobe edema, herpes encephalitis. 4 H's you shouldn't miss: hemorrhage, hydrocephalus, herniation, and herpes encephalitis. So that concludes this lecture on how to read a brain CT. Thank you very much for watching. If you have any questions, comments, or feedback, leave a message at the comment section or send me an email. Thank you very much for watching.